Good morning, everyone. I, Dr. Saurabh Mundhada, Editor Chakshu, on behalf of Team OSM 2022-23, welcome you all to the next episode of Chai Pe Charcha. Today's topic is surgical approaches to pterygium. At the outset, when a patient presents with a pterygium, the first thing to decide is whether it is necessary to do anything at all. Only a small percentage of pterygium cases warrant surgical excision. Indication of surgery includes obstruction to the visual axis, pterygium-induced irregular astigmatism, chronic eye irritation, and cosmetic dissatisfaction. Now, if you decide to surgically remove the pterygium, your next decision will be to determine how extensive a procedure is required. One day post-operative, no matter which method you use to remove the pterygium, it's going to be gone. Question is it going to come back? You want to do everything you can make sure that the answer is no. It's best to approach pterygium surgery with the goal of reducing the chances of recurrence at all cost. Today, we will seek expert guidance for the same perfection and discuss with us some surgical approaches to pterygium with particular emphasis on preventing recurrence. I hereby welcome Dr. Pankaj Lande, our guest speaker for today's Chai Pe Charcha. He is a DNB and fellow cornea surgeon from Amar Agarwal Eye Hospital, Chennai. He is currently serving as a medical director at Shri Netralaya, Amaravati. His academic interests are cornea and cataract, and he maintains a YouTube channel where he regularly teaches various surgical techniques via video. I hereby welcome Dr. Pankaj Lande to give us expert opinion on pterygium surgery, where he will be speaking on no glue, no suture technique and how to do graft harvesting with the aim of the total surgery to prevent recurrence. Over to you, Dr. Pankaj.
Thank you so much. On this occasion, I would like to thank you, Nagpur Ophthalmic Association also. Today we will be talking about the pterygium. Pterygium is a very common topic and we face these patients daily, and many of the times managing these cases is very challenging, and it is very challenging specifically when we have case which we have operated few months, few years back, and who comes with recurrent pterygium. Now, let's move to the topic without making much time pass. We will move and see how to get a perfect outcome of a pterygium surgery. Few of the tips will be useful, and I have some modifications for pterygium surgery where I use graft in a slightly different way and the method to harvest it. Now, how to get a perfect outcome in a pterygium surgery? This is a typical pterygium cases where the pupillary axis is involved. See, marking is very important in pterygium cases. I personally think that pterygium excision is over in most of our cases. So what I started is I mark all my cases so that I know that how much amount of tissue I should remove, and this precious conjunctival tissue is not cut and thrown away. So I always mark these cases. Once the marking is done, you can balloon up or you can directly cut depending on your choice. Here you can inject the mitomycin before cutting the tissue in case you have planned to use mitomycin in large size of pterygiums. A very meticulous dissection is needed, and one should not be harsh with this loose tissue. The suture is not required in this technique, and the marked area is excised with the help of scissors. Once this is done, I usually try to peel this from the head side, the conjunctival side. The cautery has to be meticulous, it should not be over. Meticulous required optimum cautery is done, and you can use a crescent knife to cut out the remaining pterygium on the head side, or you can peel it off. But while peeling, you have to be careful that superficial corneal tissue must not come into the tissue. Now, once this is done, a meticulous cautery is done. I usually take a caliper and mark the amount of graft size I need. Then after these two prongs are measured, I'll mark those prongs and place those prongs on a superficial conjunctival site, which is a host side. Here I am using a diamond burr for atraumatic smoothing of corneal surface. This instrument is very helpful, and particularly I find that it is necessary that we should use diamond burr in all our cases, because many of the times we treat the patient and we have good outcome, but the surface is not very regular. Thereby what happens, the tear distribution will not be proper in a post-operative period, and even with your successful surgery, patient will keep complaining of tearing, foreign body sensation and redness occasionally. So having a smooth regular surface which will facilitate the even distribution of tears in a post-operative period is extremely important, and it can be achieved with the help of diamond burr. So diamond burr is a must-have instrument. Now I have marked the site from where I have to take the graft. I will balloon up it with xylocaine, and to remove, what I will use is a 26 gauge needle cutting edge. I already have that mark. I will use these cutting edges of the 26 gauge very superficially, so that I will not take the tenons into it. And then underneath I will go with a, now here note the thin conjunctival flap, and you can see the marking, means you can very clearly see the forceps and the instruments below it. That indicates how thin the graft is. Now you can cut till limbus. Nowadays I am using a special forceps which I have designed for this purpose, so that it will hold this flap very nicely without traumatizing it, and it is a V-grooved diamond dusted forceps which is available with some companies. Now once this graft is taken, you can see how thin the graft is, and a very minimal amount of tissue has come, tenons tissue has come. Once this is done, it is placed over the host area and its edges are undermined, so that the chances for recurrence are very less. You can use glue or autologous serum according to your choice, but even without leaving anything, without putting any additional drops of glue, it will heal on its own. Just press a bit, make edge to edge approximation well. Some people like to have edge to edge cautery in a very low power, so that the some amount of adhesion will be there. That also helps. And I have seen my patients with this particular technique, the recurrence is very rare and the patient is very happy. This is one of the early post-op picture where you can see the underlying vessels below it, and this is in a late post-operative period. You can very well see the graft is well attached and without any issues. You can see, and there is no remaining corneal scar. If there is corneal scar, I can use my tattoo gun to tattoo the white cornea which is there, in case it is there in where it is large enough. And I thank you very much for watching this video quietly. Over to Dr. Saurabh.
Thanks, Dr. Pankaj. What a meticulous and wonderful surgery. I was thinking till date, like if I had pterygium, whom I'm going to get operated from? Being a cornea surgeon, it's a very difficult decision to take. But now looking at a video, I'm confident I'm going to book an appointment with you if in case needed. So with this, we will like to have a few questions to you.
Yes.
The first question goes related to the positioning of the graft. Does the limbal end matters in the conjunctival graft, or it doesn't matters? Like end to end, the limbal to limbal, what it is called as conjunctival limbal autograft, or it can be just a conjunctival autograft.
I would like to have a conjunctival limbal autograft, but even though you don't use conjunctival limbal autograft where there is not much of a vascularized tissue, it is okay. But whenever you have a very vascular pterygium, it is good idea that you should have limbal area in the graft.
Okay.
Otherwise, we can just have till limbus and may not involve the full of limbus.
Okay. If suppose by mistake, if during the rotation of the graft gets upside down, then how to is there any trick to identify which is the epithelial side and which is the stromal side?
Yeah. Once the graft is placed over the cornea, we can touch the graft with the help of cotton bud, and if the graft stuck to the cotton bud very easily, it is a like tenon side and not the epithelial side. The epithelial side will not touch to the this thing to cotton bud.
Okay. So, related to this thing, you have mentioned some people use cautery. So, do you prefer the same thing to, like in a no glue, no suture technique, do you prefer to use a cautery to attach the ends of the, like at the end of the graft, cautering the graft to junction?
Yes, sir. Okay, the nasal side of the graft, I would like to use the cautery, because once those are like secured, the graft folding chances goes down. Once the graft is not folded in the initial, say 48 to 72 hours, the chances that it will remain there is very high. So I will use the cautery in the corners on a nasal side.
Do you do no suture, no glue technique in all the cases, or in restrictive cases, selective cases?
In selective cases. I am not adamant on that. I would like to put the sutures if the graft is too large, if the pterygium is too fleshy. And in case where I feel the size and my dissection may not be similar all the time, okay, that can happen to any surgeon. So if something like that happen, I would like to go for glue, autologous serum, or suture, depending on the situation.
In suture, which one will you prefer?
I use 80 Vicryl, and I need not to remove them later.
Okay. What is the duration of patching you generally advise, like a post-operative for 1 day or 2 days?
Overnight.
Only 24 hours.
Yes.
Okay. If suppose on next day on follow-up, if you open the patch and sees the graft is displaced, then what is your approach to the case?
If the graft is displaced and I can see the graft, definitely I would like to take the case to the OR and use suture. And I would not like to take any other chance to use the glue or without glue. I am preferably use the suture and finish the case there itself, so that I should not have to like touch the patient once more.
What is your post-operative regime in usual cases of pterygium surgery?
I usually use one antibiotic of moxifloxacin and prednisolone in the initial 1 week with lubrication like any CMC. After 1 week, I will shift to loteprednol, and that has to be continued for 2 weeks.
Any oral medications?
Oral medications like antibiotic, painkillers, and this thing like omeprazole.
Okay.
That's it.
Thank you, Dr. Pankaj, for your wonderful presentation and very meticulous and neatly performed surgery. I will just like to request you to give any take-home message for our audience.
Yeah. Conjunctiva is a precious tissue. We should not remove it unnecessarily. So we should try to preserve as much as possible. Success of graft remaining or retaining is very high when we have no tenons with the graft. So having a thin graft is extremely important, and not to have like a mismatch in the graft size. So it is better idea that we should always use gentian violet ink and take the graft as per the need, and to have a graft and host junction in the same manner, means exactly size as that of the host side.
Okay. With this, we come to an end of this session. Once again, on behalf of Team OSN, I thank Dr. Pankaj Lande for giving his valuable input, and I hope everyone will enjoy this session with a sip of tea. Thanks again for joining us in Chai Pe Charcha. See you soon.